Part 2 of airway. All right, airway adjuncts. These are used in conjunction with manual airway maneuvers. It includes oropharyngeal and nasopharyngeal airways. All right, oropharyngeal airways are rigid, they're plastic. All right. Oh my gosh. The nasopharyngeal airways are not as rigid. They are made of plastic as well, but they're a squishy kind of plastic. Okay. All right, the adjuncts must be clean and clear of obstructions. The proper size airway must be selected to avoid complications and ineffectiveness. The airway adjuncts do not protect the airway from aspiration of secretions, blood, vomitus, or other foreign substances. The mental status of the patient will determine whether an adjunct can be used. The patient's mental status must be continually and carefully monitored. If the patient becomes more responsive or gags, remove the airway adjunct. Okay, the one in the mouth. A head tilt, chin lift, or jaw thrust must still be maintained, even when an appropriate adjunct is in place and properly positioned. Okay. All right, an oropharyngeal airway is used in patients who are unresponsive and do not have a what? Gag reflex. All right. This device must be properly sized. If it's too big, it can cause an airway obstruction. If it's too little, guess what? It can cause an airway obstruction. All right. This is what they look like. Some of them come in this nice little thing lined up like that where you can look at them. Most of them come in little Ziploc bags. Okay. Just the way EMS works. All right. So, let's talk about inserting an oral airway. Here's what we're going to do. We're going to measure the airway from the corner of the mouth to the tip of the ear. Okay? If it's too small, guess what? What are we going to do? We're going to get a bigger one. If it's too big, we're going to get a smaller one. Fantastic. Y'all are amazeballs. All right. Insert the tip pointing up to the roof of the mouth. All right, you see that little scissor technique they got going on there? That's the way you need to open the airway. If she chomps down, you can get your fingers out of there real quick like. Okay? So, we're going to start with the tip pointing toward the roof of the mouth. While advancing, we're going to rotate it 180 degrees. All right? Now, and continue until the flange rests on the teeth. All right, and this is what it should look like properly placed. All right, the airflow goes through the tube, and there's some that have a solid middle, but it's got air channels on the outside. Okay, I think I might have some in here. Let me look. We can show and tell. Pass them around. Yep, I do. All right, this is one of the ones that's solid in the middle but has the little air holes on the side. All right, I'll get a pretty orange one. Okay, and then there are some. I don't know if I have any. Oh, I do. Here's one that has the these are baby ones, but it's got the air hole in the middle. Okay. They're teeny tiny, aren't they? Okay. So
which one, like, I mean, I know they both do the same thing, but is there one that...
that's whatever your company provides. Alright? So, we're going to measure these from the corner of the mouth to the tip of the earlobe. So this would be mine. Probably. But if I ain't died in 20 years of EMS, I ain't going to die from the wrong. Alright? This would be mine. Everybody's is going to be different, probably. One like. Yeah, that's not going to be good. Alright? You're going to start up at the top and rotate it around, sliding it back. You can also start on the end and rotate around. Okay? Either one, whatever you prefer. You can start. I hate you. lab. All right.
Make sure you catch the tongue.
Yeah. Make sure you don't catch the tongue, because it can cause airway obstruction as well. Start at the top, up here, like this, because that's where it goes, and then you just flip it around as you go back in. It's supposed to sit like this in your airway. It follows the curvature.
So
All right.
question, why do you have to start at the top like that?
Because usually the tongue gets in the way. If you just go straight back in, it'll get stuck on the tongue,
Okay.
and it'll shove that tongue back down in there.
Is that easy to pull back
Oh yeah,
in?
yeah. That's why we don't start it that way. An alternative method to do this is with a tongue depressor. If you have a tongue depressor, then by all means, use it if you want to.
When you take it out, do you have to rotate it?
No, you just pull it out. All right, these are nasopharyngeal airways. This is useful in patients with clenched teeth, some facial injuries, and those unable to tolerate the OPAs or oropharyngeal airway. These should not ever be used in patients with suspected basal skull fractures or severe face trauma. Okay? This is going to go up in the nasal passage. And if they have basal or skull fractures or they have severe face trauma, where can this actually end up? In their brain. Oh, there we go.
When somebody's unconscious, do they automatically lose their gag reflex?
If they're unconscious, yes. I got a nasal airway that's coming around. Okay. It is also called an MPA. It is a curved hollow tube of soft plastic or rubber with a flange or a flare at the top end of the distal.
You're supposed to lose these, right?
Yes.
With
Yes.
water. Thanks.
KY. Yes. Be careful to select an airway of proper length. Avoid use of the nasal airway if the patient with a suspected skull fracture or a basal skull fracture or severe facial trauma. These nasal airways, they also come in different sizes, all right? In very young kids, the nasopharyngeal airway is so small that it can easily be obstructed by secretions and other airway difficulties. All right. All right, this is what it looks like. This is what some of them look like. Then you have the ones that look like this. They're also called nasal trumpets. Okay, not real sure why, but however. All right, so how do we measure this? This, we're going to measure from the corner of the nose to the earlobe. Okay? Everybody see that? Corner of the nose to the earlobe, just like this. You're going to take this out. You're going to dip the end of it in some KY jelly, water-soluble lubricant, okay? And at the end, there is a bevel, all right? The bevel always goes towards the septum, so towards the middle part, okay? You want to look at your patient's nostrils, figure out which nostril is the biggest. You have one big one, one little one. All right, everybody has one big one, one little one. All right, and you want to insert it with the bevel towards the septum.
Do the bigger one?
In the biggest one, okay? You may make some resistance. You can kind of wiggle it in. This is the importance of lubing the tube, okay? If that doesn't work, you can take it out, lube it up again, and put it in the other one, okay?
I need to be passed out for this to happen.
You can do this in response to people.
I wouldn't appreciate that.
I wouldn't appreciate it either. But however, it can be done. This is why we have these, because you can do it in response to people and not stimulate that gag reflex.
I wonder if that kind of feels like what the COVID swab was.
I don't know. I would highly suggest not trying it.
We need to tell them it's gonna hurt a little bit.
You can. All right. So this is them measuring it. from the nostril to the corner of the earlobe. They are leaving the tube. All right. The bevel's towards the septum. That's probably not a real good picture to see. But they're going in that outside nostril, so the bevel's pointed the other way. Okay. All right. Chris Letson inserts an OPA and begins positive pressure ventilations. The patient vomits again, and Chris immediately stops ventilating as Brittany helps him turn the patient onto the left side. Chris removes the OPA and suctions the patient's mouth. As Chris begins ventilation again, a second crew member arrives to assist with packaging and transport. Chris continues airway management en route to the emergency department. Soon after arriving, Chris's suspicion that the patient suffered a heroin overdose is confirmed when the emergency department administers Narcan, a drug to counteract the effects of narcotics. Within minutes, the patient is awake and talking. Now, why Chris didn't do this on scene nasally is beyond me, because this is something that we can do now, okay? All right. It is imperative to assess the relationship between the volume, which is the amount of air taken in with each breath, and the rate at which the patient is breathing when determining whether the patient is breathing adequately or not, okay? It's not just the rate, but it's the volume as well, all right? If somebody is breathing 12 times a minute, but it's really, really shallow, is that considered adequate breathing? No, they're not getting enough oxygen in, even though their rate is appropriate. Okay? So those are some things some key words when you're doing your assessments and stuff that you need to pay attention to. Okay? When you ask about what is their rate and quality of breathing? All right? Well, their rate is 12 and their quality is shallow. All right? So that automatically tells you that there is some kind of respiratory component going on here. Okay? Yeah, we just went over that. All right, tidal volume and minute volume. All right, minute volume is equal to tidal volume times your respiratory rate. Both adequate and inadequate breathing depends on two specific variables: the rate at which the patient is breathing and the depth of each breath. Because minute volume deals with both depth and rate, it typically correlates with how adequately the patient is breathing. A decrease in either tidal volume or the respiratory rate may lead to increase in minute volume, so severe that the patient is no longer moving an adequate amount of air in and out of the lungs. It is imperative to assess both rate and volume when determining the breathing is adequate, okay? That's why we teach you when you do your assessments, what is the rate and quality of my patient's breathing, all right? Only the air that reaches the alveoli can be used for gas exchange because the trachea and bronchi do not participate in gas exchange. They do not have alveoli, all right? That's where gas exchange takes place. Because of the effect of dead air space on the ventilation, small decreases in tidal volume can dramatically reduce the amount of air reaching the alveoli for gas exchange. All right? If you're breathing real shallow, do you think you're getting that air down to the base of the lungs where it needs to go? You're not. Remember, the base of the lungs is way more vascular with alveoli. Okay? That's where most of your oxygen exchange takes place. All right, so how do we assess? We look, listen, feel, and we auscultate. Okay? Remember this from CPR. Look, listen, and feel for breathing. We're going to look at their chest rise and fall. We're going to put our hand on their chest, see how far it's moving. Okay? And we're going to feel with our ear how well they're breathing. Feel for that breath coming out. All right, and the next component is we're going to auscultate. All right, we auscultate breath sounds. All right, can you hear the air going in and out? Can you hear it better on the right side versus the left side? Is it decreased in the lower lungs? All right, if it's decreased in the lower part of the lungs, we know that what's not happening? not getting the air all the way down to the bases in the alveoli where most of our air exchange takes place. Okay? So these are the places that we auscultate for lung sounds. Okay? You want to place your stethoscope at the second intercostal space, about 2 inches below the clavicle, at the mid-clavicular line. Alright? You can also auscultate at the 4th or 5th intercostal space on the anterior or mid-axillary line, or at the 5th intercostal space next to the sternum on the anterior chest. Okay? You will see a lot of times we will listen for breath sounds on the back side as well. Sometimes it's easier to hear. You can hear fluid accumulate back there as well, a lot easier. We need to know the rate, the rhythm, quality, and depth. All right? The rate falls within a range of 8 to 24 respirations per minute for an adult. Okay? Anything less than 8, you need to be bagging them. All right? Anything more than 24, you need to seriously be thinking about bagging them. All right? That positive pressure ventilation. For an adolescent, it's 12 to 20. For school age, it's 15 to 30. Infants from 6 months to preschooler is 20 to 30. And infant 30 days to 5 months is 25 to 40. All right. Newborn to 30 days is 30 to 60. Elderly have resting respiratory rates of approximately 20 breaths per minute. If the respiratory rates are too low, even though the tidal volume may be adequate, the patient will not move enough air into the lungs and alveoli to meet the oxygen demands. All right, let's talk about rhythm. All right. Rhythm is the pattern. All right. What is their breathing pattern? Is it regular? Do they take a big deep breath, hold it in, then let it out? And then they breathe really fast for 2 to 3 minutes. Okay? How regular is their pattern? Each breath should be about the same volume and come at regular intervals. However, it is normal for a patient to sigh, which alters the pattern and makes it slightly irregular. Okay? Quality. What is their quality of breathing? The breath sounds are equal and full bilaterally, okay, indicating good expansion of each lung. The chest rises and falls adequately and equally with each breath. There's no excessive accessory muscle use seen with inhalation and exhalation. It is normal for infants and children to use the abdominal muscles more than adults, okay? Depth, their tidal volume, okay? The chest will rise fully with each inhalation. The volume of air felt and heard by placing your ear next to the patient's mouth and nose will be full and adequate with each breath, okay? Are you going to do this to somebody who's sitting up in a chair? You going to go up to them and be like, okay? You're not going to have to do that to somebody that's sitting up, okay? If you want to, you can just kind of sit your hand on their chest, you know, just be like, hey, darling, what's going on today? You know, I can feel her breathe. All right, I can feel the rate with my hand. I can feel the tidal volume with my hand. All right, I don't have to go up and stick my face or my ear up against her nose and feel her breathing. All right, that's more for unresponsive. All right, table 10.3 gives you signs of adequate breathing. They have a normal rate. They have clear and equal breath sounds bilaterally. They have adequate air movement heard and felt from the nose and mouth, and they have good chest rise and fall with each ventilation. All right, common causes of respiratory arrest. All right, there are a ton of them. All right, you can have respiratory arrest due to a stroke, a heart attack, drug overdose, toxic inhalations, electrocution, lightning strikes, suffocation, traumatic injuries, airway obstruction, okay? A type of respiratory pattern that is completely inadequate and may be seen in witnessed cardiac arrest or in other conditions is called agonal breathing or agonal respirations. These are a gasping type of breathing, okay? It's usually seen when somebody's fixing to die, all right? They take a big deep breath, And they may do this 5, 6, 7, 8 times, okay? Any patient with agonal respirations must be provided with positive pressure ventilation. All right, we're going to bag these people. Respiratory rate that is either too fast or too slow, which is outside of the normal ranges were listed earlier, okay? Bradycypnia is an abnormally slow respiratory rate and an ominous sign of inadequate breathing and oxygenation, especially in infants and children. An irregular breathing pattern may indicate a severe brain injury or medical illness. Most irregular breathing patterns are also produced in inadequate rate, depth, and quality. Breath sounds that are decreased or absent indicate inadequate volume of air moving in and out of each lung with each breath. If the chest wall is not rising and falling adequately with each breath, or if the side of the chest falls unequally, the breathing is inadequate. Remember we talked about a flailed chest, a flailed segment? You have that seesaw motion. One side comes up while the other side goes down. Okay, they're not breathing adequately. Depth. The depth of breathing is shallow or inadequate. The chest wall movement is minimal and does not rise adequately with inhalation. This is referred to as shallow breathing. Shallow breathing implies an inadequate tidal volume and requires assisted ventilations. Any of these signs, a breathing rate that is too low, too high, shallow in depth, poor quality, or inadequate tidal volume, is in itself a reason to start artificial ventilation. All right, some other signs of inadequate breathing: retractions. Okay, you'll see this a lot in little kids. All right, when they take their shirt off in the emergency department, or when you're assessing them, you can see that skin fold under the rib bones. You can also see it in their neck as well. Okay, nasal flaring, abdominal breathing. They're using their accessory muscles to use. Diaphoresis. What is diaphoresis? Sweaty. Okay. Abnormal breath sounds we've already talked about. Stridor, wheezing, crackles. A silent chest. You have no breath sounds. This is bad. Very, very bad. All right. A lot of times you'll hear this with asthma patients. Like, they are so constricted they cannot move any air. All right. They won't even be wheezing. All right. You have to have air movement to wheeze. And a lot of times when you hear these bad asthmatics, you put your stethoscope on them and you listen to them and you're like, God, they're not moving any air. And you start them on a albuterol treatment. You come back and listen to them when 1 or 2 breathing treatments are done. You can finally hear them wheeze. Like, they've opened up just enough that they're starting to wheeze. All right, it's really, really cool. It's not for them, but it is for, us medical people. All right. And you can also have unequal breath sounds. This can be due to trauma, infection, and a pneumothorax. All right. Not all signs of inadequate breathing are present at the same time. Any of these signs, a high rate, a rate that's too low, shallow breathing, anything that you can classify as abnormal, okay? All right, you have to decide whether the patient needs to be ventilated or if oxygen alone is sufficient. All right, and sometimes this is kind of a fine line. All right, I'm gonna be honest with you. Even as a paramedic, sometimes it is a fine line. All right. All right, 2 adequate components must be present to have adequate breathing. All right. Only 1 inadequate component needs to be present to have inadequate breathing. There are significant psychological differences between spontaneous breathing and positive pressure ventilation. Okay? The differences are air movement, airway wall pressure, esophageal opening pressure, and cardiac output. Air movement. In normal spontaneous ventilation, the negative pressure created by increasing the size of the thorax draws air into the lungs. Positive pressure ventilation is just that. You are delivering ventilation through positive pressure. You are forcing air into the lungs regardless of the pressure changes in the thorax. With the application of positive pressure ventilation, the patient does not have to rely on their own ability to produce negative pressure. Okay? They may still have the negative pressure, but you adding a positive to it. Alright? They're going to get that lung capacity either way. Air wall pressure is not affected during normal ventilation. During positive pressure ventilation, the air walls are pushed outward, creating a larger space. This requires higher volumes to fill the large space and ventilate the patient effectively. Alright, esophageal opening. The esophagus is a soft, flexible structure. During normal ventilation, the esophagus remains collapsed and no air moves into it. Positive pressure ventilation can overcome this opening pressure, allowing air to enter the esophagus and filling the stomach with air during ventilation. This leads to gastric distension and the possibility of regurgitation or vomiting. Cardiac output. Normal spontaneous ventilation does not adversely affect the cardiac output or blood pressure. The negative pressure generated in the thorax prior to inhalation acts as a vacuum and sucks the venous blood into the inferior vena cava from the body below the level of the diaphragm. This produces an adequate amount of venous blood volume to the right side of the heart. The preload is dependent on the venous volume and amount of blood ejected from the right ventricle. An adequate preload contributes to an adequate stroke volume, cardiac output, and blood pressure. During positive pressure ventilation, the thorax becomes positive during the inhalation phase as air is forced into the lungs. With the loss of the negative pressure generated during normal ventilation, the vacuum effect is diminished and the venous return decreases. This then decreases the preload, which reduces the stroke volume, cardiac output, blood pressure, and perfusion. Some of the methods of artificial ventilation. All right, you have mouth to mouth. Yes. You have mouth to mask. Yes. All right, then you have the bag valve mask. All right, it's operated by 1 or 2 people. You must be able to maintain a good mask seal. Okay, and you have to connect it to oxygen. All right. You also have a flow restricted oxygen powered ventilation device. Alright, this is a manually triggered ventilation device. We don't use these a whole lot here because it can actually pop your lungs. As with any technique in which there is a risk of coming into contact with body fluids, it is necessary to take standard precautions when performing artificial ventilation. You need gloves, eyewear, face masks for large amounts of blood or secretions. You also need a HEPA or an N95 respirators for suspected tuberculosis or COVID-19. All right. Adequate ventilation indications. All right. They have a sufficient rate. They have sufficient and consistent tidal volume. The patient's heart rate returns to normal and their color improves. Inadequate ventilation. The rate is too slow or too fast. Chest does not rise or fall. The heart rate does not return to normal and the color does not improve. Alright, cricoid pressure was once thought to reduce complications associated with positive pressure ventilation when an unresponsive patient's airway is not protected by an advanced airway device. In this situation, the technique was intended to reduce the incidence of gastric inflation, regurgitation, and aspiration of gastric contents. However, it has been found that cricoid pressure may actually impede airflow during ventilation, and gastric inflation is best controlled by maintaining slow ventilation at a reduced volume. All right. So even though we don't use it anymore, I use this when I'm intubating somebody a lot of times. Okay, I'll ask for cric pressure. So what you do is you locate the thyroid cartilage or the Adam's apple. All right, you put a finger on each side. You press down, all right? Continue downward until you feel the base of the thyroid cartilage and below it a small, soft midline indentation. This is the cricothyroid membrane. Alright, you want to place your index finger on one side of the cricoid cartilage, your thumb on the other side, and apply firm backward pressure. Avoid compressing the cartilage. We also use the BERT. It's backward, upward, rightward pressure. You use the similar landmarks, alright? You press backward, back down, upward, up towards the base, and then right. This is supposed to align everything. And then you have the external laryngeal manipulation. This is a technique that is similar to the BERT, but you apply pressure to the cricoid cartilage. However, paramedic who's performing the laryngoscope guides the EMT's hand to provide the best melodic view. Alright. Cricoid cartilage is the only complete cartilaginous ring. When forced backwards, it may collapse the esophagus behind it. Against the cervical vertebrae, preventing air from traveling down into the stomach, and it prevents stomach contents from moving up. If the patient regurgitates, release the cricoid, burp, or ELM pressure to prevent esophageal tear. Immediately turn the patient onto their side. Proper positioning of the airway with the head tilt chin lift maneuver will help to prevent gastric inflation. Okay. This is kind of what it looks like. You're just kind of manipulating that. Mouth to mask ventilation provides adequate volumes of air for ventilating a patient. Its major limitations are the inability to deliver high concentrations of oxygen while ventilating and the risk posed to the EMTs by contact with the patient's body fluids. We use barrier devices. Okay, we have those one-way valves. Use mouth to nose ventilation when the patient's mouth cannot be opened or when severe soft tissue or bone injury has occurred to the mouth or around it in infants or kids when you cannot achieve a tight mouth to mask seal. If the patient has a pulse, the amount of air delivered to the patient should be approximately 10 milliliters per kilogram or 700 to 1,000 milliliters. Enough to make the chest rise adequately and effectively with each ventilation. Alright? Ventilation is delivered every 1 second. The patient has an advanced airway in place, the ventilation rate in the patient without a pulse is reduced to 10 per minute. One EMT provides continuous chest compressions at a rate of 100 to 120 per minute without pausing for ventilation. The ventilation should be delivered at a rate of 10 per minute, which is every 6 seconds. It is important not to overventilate the patient by providing too much ventilation, either too fast or too much volume. Okay. Decreasing the ventilation volume is aimed at reducing the incidence of gastric distension and the potential for regurgitation and aspiration. Alright. A small tidal volume reduces airway pressure and avoids causing the lower sphincter in the esophagus to open. When the stomach becomes too inflated with air, several complications may occur. The stomach filled with air may cause stomach contents to enter the esophagus, leading to aspiration. Aspiration of gastric contents may interfere with gas exchange and cause pneumonia. Also, an inflated stomach places pressure on the diaphragm, which can elevate the diaphragm and restrict its movement. When supplemental oxygen is connected, adequate oxygenation can be maintained with smaller tidal volumes. Mouth to mask is the preferred method to use when performing artificial ventilation because of the following advantages. One EMT can ventilate using the two-ended mask seal technique to achieve a better seal. The mask eliminates direct contact with the patient's nose, mouth, and secretions. You get to use a one-way valve. The method can provide adequate tidal volume and possibly greater tidal volumes than a bag valve mask. Supplemental oxygen can be administered through the oxygen inlet. Alright. Here's your pocket mask. Disadvantages. The mask is perceived by some EMTs as having an increased risk of infection. EMTs providing the ventilation may fatigue over a period of time. The device doesn't allow for the highest possible concentration of oxygen delivered. So, you're going to connect a one-way valve to the ventilation port of the mask and connect the tubing that is attached to the oxygen supply to the oxygen inlet. Set the oxygen flow rate for 15 liters per minute. Position yourself at the head of the patient. And you're going to use the EC technique to seal the mask and perform a head tilt chin lift. And you're going to blow into the ventilation port. Alright. Mouth to mask. If you suspect a patient has a spinal injury, you must establish and maintain spine motion restriction. You will ventilate the patient with the mouth to mask technique, taking care not to manipulate the head and neck during this process. It's pretty much the same process that we talked about earlier. Alright, the advantages of a BVM device over mouth-to-mouth ventilation are its convenience for EMTs and its ability to deliver enriched oxygen mixtures. Also, if two EMTs are performing the procedure, one achieves and maintains the mask seal with two hands, while the other one squeezes the bag. The device is harder to use than it looks, and the operator becomes fatigued when performing a one-person technique. It also allows for end-tidal CO2 sampling, which is a standard of care now for the EMS community as well as the hospital. It features a self-refilling bag that is disposable and easy to clean and sterilize. It's non-jamming valve system that allows a maximum oxygen inlet flow of 30 liters per minute. Either no pop-off valve or a pop-off valve that can be manually disabled. Standard 15-22 coupling for mask, endotracheal tubes, tracheostomy tubes. It'll pretty much fit anything. An oxygen inlet and a reservoir that can be connected with oxygen source to deliver at high concentrations. A true non-rebreather valve that vents the patient's exhalation and does not allow him to rebreathe any exhaled gas. We also have now that COVID is a big thing, and for patients with TB, we have a filter that goes on this exhale thing where it will filter out any TB or COVID particles from what they're breathing. It comes in a variety of sizes. You have an infant, a child, an adult, and a properly sized mask. Alright? We've already talked about all this. Alright. Procedures for two-person use of the BVM. Open the airway using the head tilt chin lift or jaw thrust maneuver. Raise the patient's head slightly with a towel or pillow to achieve a better position. Only if they are medical and not trauma. Select the correct size mask and BVM device. Place the upper narrow part of the mask over the bridge of the nose and lower it over the mouth and onto the cleft above the chin. Position your thumb over the top half of the mask and your index finger over the bottom part, and you make that EC clamp. Have another EMT connect the bag valve to the mask if it's not already attached. Begin ventilation as soon as possible. And attach it to the oxygen. If you're ventilating with a BVM and the patient's chest does not rise and fall, reevaluate the BVM device and the patient's airway. If you suspect a patient has spinal injury, you must establish and maintain spine motion restriction. Okay? So we're going to use that jaw thrust maneuver, the modified jaw thrust. Alright? You can use your knees to stabilize their head so they can't move. Or you can do it this way. Alright? Have somebody hold their head and you can ventilate. Or you can hold their head while somebody else ventilates. If you don't have enough people on scene, this is what you're going to be doing. I hope you're pretty flexible. Because if I'm sitting down here for more than like 3 or 4 minutes, I'm going to have issues getting up. Because my legs going to be asleep, my knees are going to be asleep, my thighs going to be asleep, my butt's going to be asleep. But however, it is doable. Okay? Alright, this is your two-person technique. Alright, the flow-restricted oxygen-powered ventilation device is an aid in ventilating a patient in cardiac arrest when used in the manual mode, which requires the EMT to trigger the device to deliver ventilation. You want to avoid the automatic mode in cardiac arrest because it may cause an increase in positive end expiratory pressure, which may lead to decrease in blood return. This is for adult patients only, okay? Alright, we want to check the unit to ensure that it is properly functioning. Also check the oxygen source. Open the airway. Head tilt chin lift or modified jaw thrust. Connect the flow restricted oxygen powered mask ventilation device to the mask. An adult with a pulse should be ventilated once every 5 to 6 seconds or 10 to 12 breaths per minute. An adult patient in cardiac arrest will be ventilated twice after every 30 compressions. Alright, activate the valve by depressing the trigger or button on the valve. As soon as the chest begins to rise, deactivate the valve by releasing the trigger or the button. Alright, advantages. You are free to use both hands to hold the mask and maintain the airway position. The device can be set to provide a specific tidal volume. Alarms indicate low pressure. And you can maintain spine motion restriction this way as well. You can do all three of them things at one time.